Good morning to one and all. Today we will be talking about Stemi and its management strategies. Basically, acute coronary syndrome encompasses three entities, which is unstable angina, NSTEMI, and STEMI. In case of unstable angina and NSTEMI, there is block rupture and non-occlusive thrombus. But in case of STEMI, there is an occlusive thrombus which leads to myocardial necrosis. Stable angina does not come under acute coronary syndrome. It is a completely different entity where you don't have any ECG changes. What is STEMI? ST elevation myocardial infarction represents a critical and potentially fatal subset of acute coronary syndromes. It is characterized by transmural myocardial ischemia resulting from complete coronary artery occlusion. The condition derives its name from the hallmark ST segment elevation observed on ECG. STEMI necessitates urgent recognition and intervention to minimize myocardial damage, reduce complications, and improve survival rates. Without timely management, it is associated with severe outcomes such as heart failure, malignant arrhythmias, and cardiogenic shock. It remains a significant burden on healthcare systems. Higher incidence among younger populations are in India. There is higher incidence among younger populations compared to Western demographics. The contributing factors include sedentary lifestyle, genetic predispositions, healthcare disparities, and delays in emergency response. The annual incidence varies from 25 to 50 cases per 1 lakh individuals. Men are predominantly affected in middle age, but postmenopausal women experience a higher risk. The basic mechanism of STEMI includes a rupture of an atherosclerotic block in coronary arteries, which triggers thrombus formation and leading to complete occlusion. The subsequent ischemia results in necrosis of myocardial tissue, reducing cardiac output and predisposing to arrhythmias. There is what is the pathological consequence of STEMI? The microvascular impact includes impaired perfusion and endothelial dysfunction, and the systemic manifestation is neurohormonal activation exacerbates hemodynamic instability. The symptoms include severe and persistent pain, typically radiating to the arm, neck, and jaws. But the pain in acute coronary syndrome can extend from the jawline till your umbilicus. Anywhere in between, it can be a STEMI or other forms of acute coronary syndrome. Other additional manifestation includes shortness of breath, diaphoresis, nausea, and vomiting. The physical findings may include hypotension or cardiogenic shock or hypertension due to sympathetic overdrive, along with variable arrhythmias. The ECG will show classical ST segment elevation in at least two contiguous leads, which is the diagnostic criteria. And there can also be reciprocal ST depression in opposing leads, providing additional confirmation. Biological markers which you do commonly in acute coronary syndrome are elevated troponin levels, which are basically not needed to confirm STEMI when you have an ECG criteria fulfilling the diagnosis. But it's basically helpful in other conditions where you don't have ST elevation in ECG to confirm the diagnosis of acute coronary syndrome. CPK-MB levels can also assist in diagnosis. Other imaging modalities which includes are echocardiography, which will evaluate the wall motion abnormality and the LV function, which identifies complications and will aid in the further treatment modalities. Acute management strategies. Pre-hospital phase, the immediate intervention includes administration of 325 mg of aspirin in addition to clopidogrel and statins. Sublingual nitroglycerin can be given if there is no inferior MI, and oxygen therapy is reserved for hypoxemia and for those below of 90% saturation. Hospital management includes morphine if there is pain, oxygen based on the saturation, again nitroglycerin to increase the coronary perfusion through vasodilatation, and as discussed earlier, aspirin should be given if not given in the pre-hospital phase. What are the goals of what are the methods of reperfusion therapy? Primary PCI, which is percutaneous coronary intervention, and fibrinolytic therapy. Primary PCI, percutaneous coronary intervention. What does it mean? It is the preferred modality for revascularization, offering superior outcomes compared to fibrinolytics. The procedure involves catheter-based intervention to restore blood flow in occluded arteries under fluoroscopic guidance. Optimal outcomes are achieved when there is a door-to-balloon time of less than 90 minutes. Advantages: it achieves complete myocardial reperfusion, and it reduces infarction rates, reduces recurrent ischemia, and overall mortality. This is an example of coronary artery, in which this is a picture showing the blockage through which a stent is passed, and initially it undergoes balloon dilatation followed by stent placement, thereby which the coronary will achieve reperfusion. Example of the normal coronaries, this is the left main coronary artery which divides into LAD and LCX, which in turn gives branches of OM. This is the right coronary artery where it will divide into PLB and PDA at the end. This is an example of stenosis in the LAD or left anterior descending artery. This is the result after stenting. Another example of stenosis in the right coronary artery, and this is after stenting. So primary PCI includes various complications. Vascular complication includes access site bleeding, pseudoaneurysm, AV fistula, retroperitoneal bleed, arterial dissection or thrombosis. The cardiac complication includes no reflow phenomenon, stent thrombosis which can be acute or subacute, arrhythmias, reinfarction and cardiac tamponade. Systemic complication includes contrast-induced nephropathy, allergic reactions and infections. And the procedural complication includes failure to cross the lesion, so it will be a failed procedure, guide wire entrapment, embolization and incomplete revascularization, in which you will not be able to achieve complete revascularization. Long-term complication includes restenosis, heart failure and chronic total occlusion. The other form of reperfusion strategy when the primary PCI is not possible is fibrinolytic therapy. The indication is it is utilized when PCI is unavailable within 120 minutes of the first medical contact. Administered to patients presenting within a symptom onset of 12 hours. That means fibrinolytic therapy is only effective if the window period of lysis is less than 12 hours. But the earlier is better. 12 hours is the maximum window period, but when the window period is as lesser the window period, the reperfusion rates are higher. The number of agents available for fibrinolysis are alteplase, tenecteplase, retiplase and streptokinase. Complication includes bleeding, which can be intracranial or other site bleedings, allergic reactions, and there is always the risk of reocclusion because you have not opened up the vessel. It is only the fibrinolytic therapy, not the because there can always be thrombus formation due to reinfarction, which can again cause reocclusion. The adjunctive therapy in addition to fibrinolytics will be antiplatelet agents like clopidogrels and anticoagulation in the form of low molecular heparin or unfractionated heparin. Reperfusion and long-term management. Patient has to be on dual antiplatelet therapy with aspirin and any P2Y12 inhibitor like clopidogrel, prasugrel or ticagrelor. In addition, patient will have to get beta blockers and ACE inhibitors or ARBs, which will prevent ventricular remodeling and improve the cardiac function. Beta blockers are almost directly proportional to reduce the percentage of mortality, and it can be titrated to a heart rate of 60 to 70 per minute. Statins, high intensity statins to manage dyslipidemia and to stabilize the plaques. Lifestyle modification includes smoking cessation and adoption of heart healthy diets, regular physical activity and stress management. Medication adherence is critical to prevent the recurrence of any disease. To conclude, STEMI is a medical emergency requiring immediate action. Emphasis on achieving time-sensitive benchmarks includes door to balloon and door to needle time. Comprehensive management including advanced reperfusion techniques, pharmacological adjuncts and preventive care is essential to optimize the output of a STEMI. Thank you.